The lecture today about the pharmacotherapy of the diabetes mellitus. The objective of this lecture are identification of the effect of drugs on the insulin synthesis and release, outline the classification of insulin preparation and their pharmacokinetics, explain the mechanism of action and adverse reaction and therapeutic uses of insulin, outline the classification of oral hypoglycemic agent or oral anti-diabetic agent, describe the mechanism, pharmacokinetic, adverse reaction of different groups, list the major drug-drug interaction and complementary medicine. Introduction. Diabetes mellitus is a common metabolic disorder that lead to hyperglycemia. Both genetic and environmental factors contribute to its pathogenesis, including insufficient insulin secretion, reduced response to endogenous or exogenous insulin, increased glucose production and or abnormality in the fat and protein metabolism. Chronic complications that arise from prolonged hyperglycemia include retinopathy, neuropathy, nephropathy, and cardiovascular diseases. These chronic complications fortunately can be reduced by sustained control of blood glucose. All forms of diabetes mellitus are caused by decrease in the circulated concentration of the insulin, means insulin deficiency, and decrease in the response of the peripheral tissue to insulin action, means insulin resistance. We have two types of the diabetes mellitus. Type 1 diabetes mellitus, formerly or in the previous was named juvenile diabetes or insulin-dependent diabetes mellitus. And second type is type 2 diabetes mellitus, previously named adult onset diabetes or non-insulin diabetic or non-insulin dependent diabetes mellitus. Diabetes mellitus is diagnosed by symptoms of hyperglycemia like polyuria, polydyspepsia, and polyphagia, loss of body weight and easy fatigability plus random blood glucose more than 12.1 millimolar or 200 milligram per deciliter, in addition to glycated hemoglobin more than 6.5%. Insulin synthesis. Insulin is synthesized in the beta cells in the pancreatic islets, contain alpha cells that secrete glucagon and beta cells that secrete insulin, and gamma cells that secrete somatostatin. Insulin is synthesized initially as a single polypeptide called pre-proinsulin, which change into proinsulin followed by sulfur bonds, which lastly end by synthesis of both insulin molecules, 51 amino acid arranged into peptide chains, in addition to C-peptide or 31 amino acid separate chain. Insulin and C-peptide are stored in granules and co-secreted in equimolar quantities. The half-life of insulin is about 5 to 6 minutes due to extensive hepatic clearance. C-peptide has no known physiological function and its half-life is about 30 minutes. C-peptide is released from portal vein into the peripheral circulation where it can be measured. Therefore, this peptide is useful in assessment of secretory function of the beta cells of the pancreas. Insulin release. Glucose is the primary insulin secretagogue, and once glucose enters the beta cells through glucose transporter GLUT, it changes into glucose 6-phosphate, which is metabolized by glycolysis releasing ATP. This is the mechanism of the release of the insulin. Pancreatic islets are richly innervated by both adrenergic and cholinergic nerve. Stimulation of alpha-2 adrenergic receptor inhibit insulin secretion, whereas beta-2 adrenergic receptor antagonist and vagal nerve stimulation enhance release. In general, any condition that stimulates sympathetic branch of autonomic nervous system as hypoglycemia, hypoxia, burn, surge, inhibit insulin release by stimulation of alpha-2 adrenergic receptor. Also, beta-2 antagonist and somatostatin and glucagon inhibit insulin secretion. This figure explains the relation between the glucagon release and insulin release. The low blood sugar can stimulate the release of glucagon, and at end it will increase glucose in bloodstream. However, high blood sugar stimulates the insulin release and at end decrease glucose in the bloodstream. Mechanism of the release of insulin from islet beta cell. Inward potassium or sulfonylurea receptors are the two components of ATP, potassium ATP channels. The pancreatic alpha cell, which has similarity to beta cell, secrete glucagon in response primarily to hypoglycemia. In general, glucagon and insulin secretion are regulated in the reciprocal way or reverse way, that is, the agent or processes that stimulate insulin secretion inhibit glucagon secretion. Exceptions are the arginine, which stimulates secretion of both hormones, and somatostatin, which inhibits their secretion. One of the famous drugs which can decrease the insulin secretion is diazoxide. Diazoxide is arterial dilator and used mainly to decrease the hypertension by arterial vasodilatation. This drug reduces insulin secretion by activating ATP sensitive channels. This is the opposite effect to that of the sulfonylurea. This drug is used to treat hypoglycemia secondary to insulinemia because it blocks the release of insulin. Insulin action. Insulin is an anabolic hormone. It increases the uptake, use, and storage of major nutrients, glucose, lipid, and amino acid. It stimulates the glucogenesis, lipogenesis, and protein synthesis, while inhibits the catabolism of these compounds. The insulin therapy means use insulin as therapeutic agent. First of all, you should know the source of the insulin. We have now only one source of the insulin is the human insulin, which is produced by recombinant DNA technology from E. coli or yeast, and it is the main type of insulin used now. Previously, insulin was produced from animal source. This human insulin, it has replaced insulin of animal source, as it is less immunogenic and lower incidence of development. We can conclude that the human insulin is more advantageous than animal insulin in two items. First, it is less immunogenic, means less inducing allergy. Second, it less induce insulin resistance. Doses and concentration of clinically used insulin preparation are expressed in the international unit. 1 unit of insulin is defined as the amount of insulin required to reduce the blood glucose concentration in a fasting rapid to 45 milligrams. Means 1 unit can reduce blood sugar by 45 milligram per dl. We should know the insulin level secreted in human is about 20 to 40 units daily. Half of this amount is secreted in the basal state to suppress lipolysis, proteolysis, and hepatic glucose production, and the other half is secreted in response to meals or postprandial insulin. This is the daily secretion of insulin in human, or human need about 20 to 4 units per day, half of them as a basal and half to prevent the postprandial hyperglycemia. Insulin preparation are classified according to their duration of action into short, intermediate, and long acting. Regular insulin mainly considered as short acting. It can be used subcutaneous, intravenous, and intramuscular, and can be used in emergency and intravenous. NPH or neutral protamine Higdorn, a native insulin complexed with zinc and protamine and phosphate buffer at neutral pH. From table we can select long-acting glargine lantus at breakfast, daily once injection, which give 20 to 24 hour action, and another short acting or rapid acting like Lispro or Humalog. This type has short onset of action and prevent the postprandial hyperglycemia. This curve demonstrates the level of different type of the preparation of insulin. As we see, the glargine curve give maintenance or base level of insulin for about 20 to 26 hours and no spikes. However, the rapid acting or short acting aspartate and lispro give spikes after 10 to 15 minutes and has short duration of action. Second adverse action, lipid dystrophy and lipoatrophy, atrophy of subcutaneous fat at site of injection, was a rare side effect observed with older insulin preparation, and now is less than the other because there is no immunogenic effect. Lipohypertrophy, enlargement of subcutaneous fat ascribed to lipogenic action of the insulin. Allergic reaction. This is the fourth adverse reaction. This side effect is less now. The incidence is low with the use of the human insulin or recombinant human insulin. Therapeutic uses. Mainly this preparation of insulin is used with type 1 insulin or insulin dependent type. Type 2 also can use insulin preparation and the certain condition or certain cases. First of these condition, admission to intensive care due to severe illness, severe infection, pregnancy, surgery, pain, and diabetic ketoacidosis or hyperglycemic coma. Also failure to control glucose level by oral hypoglycemic or oral anti-diabetic aid. This is the last slide about the insulin uses for pharmacotherapy. Second, I have two groups can induce insulin secretions, named sulfonylurease group and the non-sulfonylurease group. The two groups, sulfonylurease and the non-sulfonylurease, act by the same mechanism, which inhibit the efflux of potassium and decrease calcium enteriness and increase the release of the insulin. The first one, sulfonylurease, we have three generations, or sometimes classified as two generations. First generation, which is the old members, or are terbitamide and chlorobromide. These two drugs are not used now due to high adverse reaction and very long duration, which can cause exhaustion of the beta islet. Second generation is glibenclamide and glibenclamide and glibizide and glibiclazide. The glibenclamide, Amaryl, considered by some reference as third generation because it has advantage more than glibenclamide and gliclazide, as it less side effect than aspirin. The non-sulfonyl groups are Meglitinide or Meglitinide. These all names for non-sulfonyl group. Meglitinide, like ribaglinide and nitaglinide. The two groups, sulfonylurease and non-sulfonylurease group, the only group can produce hypoglycemia with high dose. The second drug group are that drug which can alter insulin action, means drugs can improve the sensitivity of the insulin receptor in the periphery. First of this group, biguanide. This biguanide act by activation of adenosine monophosphate kinase protein. Example, Metformin. The second group improves the insulin sensitivity, are named insulin sensitizer, thiazolidinediones. Example, resiglitazone. The third group, which can decrease the absorption of glucose from intestine, or alpha-glucosidase inhibitors like acrobase and meglitinide. These drugs just inhibit the absorption from GIT for carbohydrate. The fourth group and fifth group depend on the action of the incretin. The fourth group, named glucagon-like peptide or incretin-like drugs. These drugs only administered by parenteral, like liraglutide. Until now, no oral form for this group. The second group linked with glucagon-like peptide or incretin is dipeptidyl peptidase 4 inhibitor. This group inhibit the enzymes responsible for destruction of incretin or glucagon-like peptide. Example of these drugs are vildagliptin or sitagliptin, which are the most recent used oral anti-diabetic. The sixth group, sodium glucose co-transporter inhibitor. This group of drug inhibit the reabsorption, tubular reabsorption of glucose and enhance secretion of glucose. The other group, like meglitinide and bile acid binding resin, bromocriptin, these are not majorly used for treatment of the diabetes. We start with sulfonylurea group. As we know from the classification, the sulfonylureas and the non-sulfonyl groups, their action depends on the secretion of insulin. Therefore, these drugs are hypoglycemic agents. The action mainly depends on the inhibit the potassium efflux or closure of potassium channels and inhibition of potassium conductor, lead to depolarization of beta cells and calcium-dependent exocytosis of the stored insulin. As we show in the graph, insulin secreted after the calcium-induced exocytosis. The calcium enter after inhibit the potassium channels or close potassium channel, which induce hyper or induce depolarization. The summary for the action of this group: In the beta cell receptor binding, sulfonylurea induce closure of potassium channels and opening of calcium channels. Opening of calcium channels increase calcium intracellular, lead to translocation of secretory granules or oxidosis and insulin release outside the cell. Used in hyperglycemia in type 2 diabetes after failure of diet control. Secondary failure in response may result from change in drug metabolism or more likely from progress of the beta cell failure. It is essential for that drugs the function of the beta cell is act at least 30% of the ability of the beta cell is still acting. So sulfonylureas cannot produce any action and the patient have islet of Langerhans of function less than 30%. Adverse reaction: hypoglycemia, particularly in the elderly patient with impaired hepatic or renal function who are taking longer acting sulfonylurea. Weight gain related to improving glycemic control. And less frequent side effects like nausea, vomiting, cholestatic jaundice, and agranulocytosis, plastic anemia, hemolytic anemia, and hypersensitive reaction. There is debate about the effect of sulfonylurea on the cardiovascular. There are many reports about increase the cardiovascular mortality due to long use of the sulfonylurea. Drug interaction: some drug displays the sulfonylurea from binding to plasma protein, causing transient increase of free drug concentration and enhancement of hypoglycemic effect. Examples are sulfonamide and salicylate. Hypoglycemic action of sulfonylurea may be enhanced by concomitant intake of ethanol. On the other hand, some other drugs may reduce the glucose-lowering effect of sulfonylureas, like calcium channel blocker. Calcium channel blocker and diazoxide and estrogen have anti-sulfonylurea action or reduce the action of the sulfonylurea and the non-sulfonylurea. Clinical pharmacology report about the sulfonylurea drugs. The first generation is rarely used now in the treatment, and the second generation are more potent and widely used. Chloromide, the first generation, prolonged biologic effect with severe hypoglycemia, especially in the early. Glipizide, it is rapid absorbed from intestine. It is delayed if taken with food, so it should be given 30 minutes before meal. Glycoside, dimacron, has intermediate action with duration of about 12 hours. Glimepiride, Emeril, has long duration of action and given once daily. It is most effective as lowering blood glucose with lowest dose of any sulfonylurea compound. Non-sulfonylurea, Meglitinide or Meglitinide, Example, Meglitinide and Incretin act by the same mechanism. They are structurally related to sulfonylurea, but like sulfonylurea, they stimulate insulin release by closure of the ATP-sensitive potassium channels or potassium channels in pancreatic beta cells. They have rapid onset and short duration of action that allow multiple pre-prandial uses, I means used before meal, for glycemic control in comparison with the classical sulfonylurea. They are metabolized primarily in the liver, and those should be adjusted in hepatic insufficiency. Their side effects include hypoglycemia and secondary failure after initially improving glycemic control. So they are not therapeutically better than sulfonylurea, especially they are also expensive. The third group of oral anti-diabetic, this group of drugs which improves the sensitivity of insulin receptor, AMP activator or 5-adenosine monophosphate activating protein kinase activator. Biguanide or metformin. Mechanism of action. Metformin primary action is on liver. It increases the activity of the AMP-dependent protein kinase. This enzyme acts basically as an intracellular injury sensor. It is activated when cellular injury stores are reduced. Activation of AMPK stimulate fatty acid oxidation, glucose uptake, reduce lipogenesis and glucogenesis. The net result of this action is increased glycogen storage in the skeletal muscle, lower rate of the hepatic glucose production, increased insulin sensitivity, and lower blood glucose level. Metformin has little effect on the normal blood glucose and does not affect the release of insulin or other islet hormone and rarely cause hypoglycemia. Pharmacokinetic of metformin. The drug does not bind to plasma protein and excreted unchanged by kidney. Its half-life is about 2 hours. The drug is transported by organic transporter to target tissue, particularly liver and skeletal muscle, for pharmacological effect. Mutation in that transporter can affect its efficacy. Organic transporter is the transporter of the drug to kidney for elimination. Therapeutic uses. It is effective as monotherapy and in combination with other oral antidiabetic or insulin in treatment of type 2. It has the benefit of improving fasting or postprandial hyperglycemia in obese patients without the weight gain associated with insulin or sulfonylurea therapy. Furthermore, it lowers cardiovascular mortality compared with other anti-diabetic oral agents. Treatment of infertility. The second use of the metformin in treatment of infertility in women with polycystic ovary syndrome. It improves ovulation and menstrual cyclicity and reduce circulation and reduce circulating androgens. Adverse reaction: gastrointestinal effect like nausea, abdominal distension, diarrhea, and or abdominal cramp. The more serious side effect, and also it is rare, lactoacidosis. It is rare complication. However, it can be seen with higher dose of metformin when patient has concurrent disease that cause poor tissue perfusion like sepsis, myocardial infarction, conjunctive heart failure or renal failure. Reduced bile salt, glucose, vitamin B12 absorption due to drug-induced malabsorption. This can be overcome by starting at low doses of drug and gradually increase to target levels. The fourth adverse action is drug interaction. Cationic drugs can compete with metformin for common renal transport system. Examples are cimetidine, furosemide, and nifedipine. Contraindication: type 1 diabetes and type 2 diabetes in patients with hepatic or renal insufficiency and alcoholism. So it is not used in type 1 or type 2 in patients with hepatic or renal insufficiency or alcoholism. The other group, cyanosilamide or 4-PPAR gamma activator. This group act by activation certain nuclear hormone or nuclear receptors named peroxisome proliferation activating receptor gamma or PPAR gamma. These receptors affect the expression of gene-related glucose and lipid metabolism, leading to increased glucose transporter expression and insulin-mediated glucose uptake, but decrease the hepatic glucose uptake, and also increase tissue sensitivity to insulin and elevated insulin-mediated and reduced hepatic production of glucose. Means it sensitizes the peripheral tissue to insulin or sensitizes the insulin receptor. In adipose tissue, adipocyte differentiation and adiponectin production from adipocyte. Adiponectin sensitizes tissue to the effect of insulin. Also, the uptake of circulating fatty acid into fat cells is promoted and lipolysis is reduced. Therapeutic uses of the insulin sensitizer: they are effective either alone or combined with insulin, metformin, or sulfonylurea in treatment of type 2 diabetes. The onset of action of glitazone or thiazidinediones in glycemic control is slow, with maximal effect not before 1 to 3 months. This is very important mark. The action of thiazidinediones or glitazones appear after more than 1 month. The combination with metformin has the advantage of not causing hypoglycemia when given with insulin and type 2 diabetes. The dose of insulin given can be reduced by 30 to 50%. Adverse action: weight gain and edema. Macular edema in the eye may occur, and therefore eye examination periodically must be done. Increased risk of heart failure due to edema and expansion of the plasma volume. Resiglitazone, but not bioglitazone, increase the risk of myocardial infarction and stroke. Resiglitazone is not used now, and only bioglitazone is used. Increase of risk of bone fracture in women. The FDA recommends use of the resiglitazone in type 2 diabetes only when the disease is not controlled by other agents, including bioglitazone. The European market nearly has withdrawn the resiglitazone. The fifth groups, or the two groups linked to incretin or glucagon-like peptide hormone. We know that incretin or glucagon-like peptide is hormonal peptide from GIT stimulate the secretion of insulin and facilitate the control of glucose level. We have two groups of drugs. One group of drugs like incretin means have action like incretin, named incretin or glucagon like peptide. And another group of drugs can inhibit the enzymes which destruct the incretin. This enzyme is peptidase enzyme. Peptidase enzyme 4 can destruct the incretin. The group of drug can inhibit that enzyme and spare incretin to stimulate release of insulin. Glucagon like peptide agonist oral glucose produce a 3-fold to 4-fold higher insulin response than equivalent dose of glucose given intravenous. This is because oral glucose causes a release of gut hormone such as glucagon like peptide and glucose dependent insulin tropic polypeptide or glucagon like peptide like incretin that amplify glucose induced insulin release. This incretin effect is reduced in patients with type 2 diabetes. Glucagon like peptide secretion is impaired in type 2 diabetes. When glucagon like peptide is infused in patients with type 2, it stimulates the insulin secretion and lower glucose level. Glucagon like peptide 1 inhibitor has lower risk for hypoglycemia as it has modest insulin stimulatory effect. Example of synthetic glucagon like peptide receptor agonists are liraglutide or exenatide. Liraglutide is more famous and used only by parenteral. They can be combined with Metformin or Sulfonylurea or both. Side effect: nausea and vomiting as well as weight loss. The other group linked to hormonal gut hormones, peptidase 4 inhibitors. Peptidase 4 enzyme is protease enzyme widely distributed in the body and specifically inactivates the incretin glucagon like peptide, which become inactive as insulin secretagogue. Treatment with peptidase inhibitor like sitagliptin and vildagliptin causes elevation of glucagon like peptide in plasma concentration and is associated with both increased insulin secretion and reduced glucose level. Consequently, both fasting and postprandial hyperglycemia are improved. Sitagliptin has an oral bioavailability of over 85%, achieve peak concentration within 1 to 4 hours, and has half-life of approximately 12 hours. Common adverse effects include nasopharyngitis, upper respiratory infection, and headaches. Hypoglycemia can occur when the drug is combined with insulin secretagogue or insulin. Saxagliptin is given orally, and reach maximal concentration within 2 hours, 4 hours for its active metabolite. Adverse effects include an increased rate of infection, headache, and hypersensitivity reaction like urticaria and facial edema. Vildagliptin lower HbA1c level by 0.5 to 1% when added to therapeutic regimen of patients with type 2 diabetes. Adverse reactions include upper respiratory infection, nasopharyngitis, dyspnea, and headache. Rarely it can cause hepatitis, and liver function tests should be performed. The last group, which depend on the inhibits absorption of glucose from GIT. Acrobase or megaglutol can inhibit alpha-glucosidase enzyme located on the intestinal brush border, leading to slowing of the absorption of carbohydrate from gastrointestinal tract, and it reduces the rate of rise of postprandial plasma glucose. They do not induce hypoglycemia when given alone. Acrobase is minimally absorbed from the intestine. Adverse effect: the most common is malabsorption, flatulence, and diarrhea because they do not stimulate insulin release. Another group, sodium glucose co-transporter inhibitor. This group depends on inhibit the reabsorption of glucose in the tubules of the kidney, where glucose is freely filtered by the renal villi, and 90% of glucose reabsorbed in the proximal tubules by the action of sodium glucose transporter. Sodium glucose transporter inhibition causes glucosuria and lower glucose level in the patient with type 2. Inhibition of the reabsorption of glucose or inhibit the sodium glucose transporter can lead to increase the glucose with urine, increased excretion of glucose with the urine. Example of these drugs are dapagliflozin and empagliflozin. Their efficacy is reduced in chronic kidney disease. Canagliflozin and empagliflozin are contraindicated in patients with estimated glomerular filtration rate less than 45 ml per minute. The main side effects are increased incidence of the genital infections and urinary tract infection. The main side effect is the increased genital infection and urinary tract infection. About 80 to 90% of patients suffer from the increased infection in the urinary tract. The osmotic diuresis can also cause intravascular volume contraction and hypotension. Para-amylotinide, this synthesis from amylin developed to bind to amylin receptor, causing reduction in glucagon release, delay gastric empty, and satiety. It is given as subcutaneous injection prior to meals. It has been approved as adjunct therapy in patients with type 1 or type 2. Meglitinide has the advantage of achieving weight loss when added to insulin at mealtime. It enhances the rate of hyperglycemia. Therefore, the drug has advantage sparing effect to insulin doses, which can be reduced the previous presence of women to avoid hypoxia. Adverse effect nausea, and presence of insulin. It increases the rate of hypoglycemia. Complementary medicine. The most important complementary medicine is exercise. It is one of the best treatments to control type 2 diabetes. It is also recommended for type 1, but patients should be careful when they are at risk for hypoglycemic episodes. Diet control, effective complementary treatment, food supplement, and herbs. These herbs or food has minimal efficacy, like garlic, onion, ginseng, cinnamon, fenugreek, alpha-glucosidase acid, omega-3 fatty acid, chromium, ginseng. All these herbs or food has little effect, so we cannot depend on these in treatment, but can be used as adjuvant treatment. This is the end of the lecture.